Hello everyone, my name is Georgios Grigoriadis, and I would like to thank the Embryolab Clinic for the kind invitation to give this talk on surgical indications of endometriosis. You can see the website of EndometriosisNet, which includes both information in English as well as in Greek, where you can find the relevant links on the social media as well. Few words about me. I'm a graduate of the University of Crete Medical School. I specialized in OBGYN in the United Kingdom, and I'm a member of the Royal College of Obstetricians and Gynecologists. I worked as an NHS consultant in obstetrics and gynecology, and then completed a fellowship in endometriosis surgery in Bordeaux with Professor Ras Roman, been one of the largest endometriosis centers in Europe, and I have no conflicts of interest to declare for this talk. When it comes to setting the goals for this talk, it's important to keep in mind that speak as a surgeon from the surgeon standpoint. And the aim of my talk is to discuss a little bit about the latest ESRA guideline for the management of endometriosis 2022, and focus a little bit on the role of endoscopic surgery in the management of pain, as well as infertility, with a special reference to unexplained infertility, as well as events of previous failed IVF or IVFs, and finally conclude with a proposed pathway of care when it comes to indications for surgery. Talking about evidence in endometriosis, we must always keep in mind that the quality of evidence in many cases may be of low or moderate quality at best, for a variety of reasons which I'm not going to talk into great detail here. With this in mind, we'll look at the latest guideline 2022, which replaced the previous 2014 guideline. The same society has also issued two papers with surgical recommendations, one for deep endometriosis, the other for endometriomas, which are not again the subject of this talk. Now, as regards the pain, the ESRA guidelines, the authors advise us to offer surgery as one of the methods to reduce pain, as well as to consider the excision instead of ablation of the lesions, although this is a rather weak recommendation, as they state. In case of endometriomas, they suggest surgical resection, as it is associated with reduction in recurrence and potentially pain. Although I must admit that many clinicians which I have worked with may have a different view on this one for women of childbearing potential. As for deep endometriosis, the authors suggest that surgical excision can be considered, as it may be related to improvements in pain and quality of life. They also do recognize the need for those complex cases to be referred to specialist centers, and only following discussion with the patient on risks, potential benefits, etc., then to potentially proceed with surgery if indicated. Having a look at the actual evidence we have in terms of cases of mild to moderate disease, we're starting by this RCT back in 1994 by Sutton and others, 63 patients with stage 1 to 3 disease. They compared laser adhesiolysis versus diagnostic laparoscopy. Patients were evaluated 6 months post-operatively, and another one by Abbott, RCT of 39 patients with stages 2 to 4 in this case, excision versus diagnostic laparoscopy. It is rather difficult to exclude the placebo effect. However, both studies suggested that surgical management in mild to moderate disease yielded satisfactory results. However, they did not demonstrate any significant difference between laser and excision of the lesions. Moving on to severe disease, a systematic review by Arcoverde 2019 of 38 studies, with 30 of those focusing on DIE, deep infiltrating disease, with a number of more than 2,000 patients. They demonstrated improvements in quality of life, specifically in the somatic pain. There's a number of observational studies that seem to conclude similar results. However, when we have a look at the Cochrane database in 2020, including 14 RCTs, they do state that compared to diagnostic laparoscopy only, it is uncertain whether laparoscopic surgery reduces overall pain associated with minimal to severe endometriosis. However, they do acknowledge that the quality of evidence is of very low quality. When we talk about surgery, and particularly for deep disease, we need to talk about complications. Certainly this paper by Ben DiFalla, recent paper, systematic review meta-analysis of 60 studies looking at the complications, identified that serious complications do occur in up to almost 10% of cases, and it makes sense that they seem to be less frequent in cases of less radical surgery, more conservative surgery. Similar results by other retrospective studies. The last one by Abo came to the interesting conclusion that 1 year postoperatively, patients had similar pregnancy rates whether they had actually suffered a serious complication or not. That doesn't seem to affect significantly the chances of them getting pregnant. When we're talking about colorectal endometriosis, we're talking about Lara syndrome and what is the risk of that. The only randomized study that I'm aware of comparing conservative to more radical surgery actually came to the conclusion that both types of surgery have rather similar functional outcomes. However, the only thing that significantly differed between the two was the fact that colorectal resection was associated with a higher rate of stenosis of the anastomosis. Now, when it comes to recurrence, this is always a concern in endometriosis surgery, and we know that this can happen in 15% of the cases. But what is also very interesting to note and counsel our patients appropriately is that when we do operate for recurrent disease, the risk of severe complications, Clavendin 3 and 4, more than doubles from 6 to 14% in repeat surgeries, and that is important. Moving on now to endometriosis and infertility and what is the role of surgery. The authors identify patients as those who wish to have a spontaneous conception and those that will have IVF. For the first group, they do then recognize 3 different subgroups: those with mild disease, those with endometriomas, and those with DIE. As regards mild disease, they do state that surgery could be offered as a treatment option for stage 1 to 2 disease, as it seems to improve rate of ongoing pregnancy. Similarly, for endometrioma, it may increase the chance of natural pregnancy, although we have no data from comparative studies. And as regards the DIE, they do state that although no compelling evidence exists that surgery improves fertility, it may represent a valid option, a treatment option, particularly in symptomatic patients. It needs to be borne in mind that all these are weak recommendations, as you can see here. What about the patients that would benefit from ART, artificial reproductive technology? Is there a role for surgery as an adjunct prior to assisted reproduction? Again, the authors identify mild cases with endometrioma and DIE. Here the recommendations are strong. As regards the mild disease, I say that there's no role in surgery. clearly for the mild disease endometriomas. Again, they say that it's not recommended prior to ART, as the current evidence shows no benefit, and actually it may potentially harm and reduce the ovarian reserve. However, one needs to consider that it may improve endometriosis associated pain or accessibility of follicles. And when it comes to DIE, deep disease, they do say that prior to ART, it could be considered, but it should be guided mainly by the symptom and the patient preference, as we do not have randomized studies clearly stating whether surgery yields any benefit in terms of the fertility. As I said in the beginning of my talk, I would like to focus a little bit on the unexplained infertility. There appears to be a tendency in the last years to rather avoid performing diagnostic laparoscopy and jump straight to ART. This study actually from 2009 of 57 patients with normal hysterosalpingogram and unexplained infertility who underwent diagnostic laparoscopy found endometriosis in more than 50% of the cases, 63%, varying from mild to severe disease. All were managed by bipolar diathermy, according to the authors. They do state that the pregnancy rate was 50.9%. 6 of those cases were ART, and as you can see, the rest were not ART. We have 23 and 6 were by ART. What is also interesting that you can see here that the chances of pregnancy increased significantly in the first year after surgery, and then they reached a plateau, which again demonstrates the beneficial role of surgery in those cases. They do conclude, the authors, that diagnostic laparoscopy should be offered in such cases before ART. However, of course, this is not the only opinion out there. This opinion paper in Human Reproduction 2002 regarding unexplained infertility, the authors state that laparoscopy should be avoided. They do state that 3 to 6 cycles of gonadotrophins with IUI, if that fails, failing that, one should go to ART. There's no point in laparoscopy because their reason for them stating that is that first, we know that ART brings a very good result in terms of chances of pregnancy, but they also state that potentially identifying endometriosis and treating it may not have any actual effect. They're not convinced that any endometriosis in such cases could be anything more than an incidental finding, essentially. But it is worth noting at that point of that study from Marku, 1997, actually goes back a long time in the New England, very well organized randomized controlled trial of patients with minimal or mild endometriosis, those that underwent laparoscopic treatment versus those that had just a diagnostic laparoscopy, and they did demonstrate that there was statistically significant pregnancy rates in those that received laparoscopic treatment. So that needs to be borne in mind. Unsuccessful IVF, that is another group that endoscopy may have a role, but that's again controversy, a debatable thing for many. There's a paper from Fertility and Sterility. We have in a tertiary center 29 patients that had from 1 to 5 failed IVFs. 3 of them had known endometriosis before surgery. Now you can see that those that underwent laparoscopy were compared to those that did not undergo laparoscopy, and there was a statistically significant difference favoring the laparoscopy group, both in terms of pregnancy rate as well as spontaneous pregnancy rate. Therefore, the authors do conclude stating that in patients with failed IVF, meticulous laparoscopic evaluation and treatment by a skilled surgeon is recommended. They also go on to say that they would not classify an infertility condition as unexplained without confirming the absence of endometriosis by thorough laparoscopy. In their center, patients under 35 years of age, they have excellent chances of pregnancy following surgical treatment without ART. However, of course, they do acknowledge that those findings need to be evaluated and confirmed by multi-center randomized clinical trials. Moving on to my flowchart, this is my personal view on the role of endoscopy in cases of endometriosis with pain. I'm not suggesting that this is the only right way to do it. This is just my experience and how I do it. In terms of patients that present to you with pain, and this is their main presenting complaint, I feel that medical management first has a role, and it is valid to offer that first. Of course, there are some patients that are not good candidates for medical hormonal management, and those are patients that have current pregnancy wish, patients that have contraindication to hormones or not wishing to take hormones for whatever reasons. Cases of emergency cases, urgent cases, I'm talking about potential ureteric stenosis or bowel obstruction, risk of malignancy in case of endometrioma, lesion enlargement despite the use of hormones. These are all cases where endoscopy is valid. Again, patients that have had a medical management and they have not experienced any improvement, or they suffer bad side effects and they wish to stop it, again, they also should be guided towards endoscopy. So this is what I do when patients present with pain. Now, when infertility is the main concern or the only concern, it's not unreasonable to guide a patient towards ART if the infertility is asymptomatic in terms of pain. Now, endoscopy comes in when you have patients that may also have symptoms of endometriosis, particularly those that potentially dyspareunia or pain may prevent them from having regular intercourse. Also patients that do not wish to have ART. Patients with endometriomas, this is mainly for cases where the infertility specialist cannot access the follicles as they should, so surgical intervention is not unreasonable in that case. And I'm putting a question mark as regard unexplained infertility. In my view, I do still think that before putting the tag of unexplained infertility, it is reasonable to perform a diagnostic laparoscopy and treat any endometriosis that you may find, and therefore guide the postoperative plan accordingly. And also certainly think that failed ART is also an indication for endoscopy in patients with endometriosis. Some authors quote that this should be 2 or more failed ARTs, and that is also my practice. So these cases should, in my view, undergo endoscopic management, and then depending, of course, on many parameters, mainly the endometriosis fertility index that we identify intraoperatively, then we can guide the patients to either try for spontaneous conception for a number of months. I usually recommend up to a year postoperatively, or in cases where, of course, the tubes are in very bad condition, then it's not unreasonable to guide the patient straight to ART. And this is my management of patients who present with infertility. This brings me to the end of this talk. I thank you very much again. I thank Embryolab. This is EndometriosisNet. I would like to I'm happy to take any questions that you may have. Thank you so much.